posterior chain. So you start to think of chains of muscles, right? Muscles don't work independently. When we walk, we don't only use glute max. We use all the muscles in this chain, go from here all the way up to here. So if we do it correctly, we primarily use the glute max. If we do it incorrectly, the glute max becomes weak, or the better word,
inhibited.
We use the compensatory muscles. The main ones we use are the hamstrings, calf, paraspinals. You can also use the key line. You can see the paraspinals all the way to here. So everybody get up. Now walk without using your glute max. Use your compensatory muscles. Right? You don't use your glute max, use your hamstrings and your back to push yourself forward. You can do it, right? Let's say you had your glute max surgically removed. You had to walk without it. You have to just push and use the other posterior chain muscles, right? So, if the glute max becomes inhibited, what happens is people start overusing those muscles. Now, the primary, who was talking today about ankles? What's the main reason the glute max becomes inhibited? Who did I talk about ankles? What happened? Why does the glute max become inhibited?
I think it was in relation to the inversion ankle sprain.
Ankle sprains. Okay, if ankle sprains aren't properly rehabbed, it works up the kinetic chain, and the glute max just says, okay, I'm on vacation. I'm done. The other muscles start to take over. You'll see it. Somebody will come in, they'll have chronic SI problems, they'll have knee problems, you'll see some of the visual signs, and you'll go, okay, was it about 2 years ago you sprained your ankle? And they're like, yeah, it was. So it's a pretty strong correlation. All right, so let's have you face over here. Notice what we've done now. Cross your arms. Right, what you done? Even a better way than the belly shirt. All right, what are the signs, if we look for visual signs of an inhibited glute max, what would they be? Okay. Sagging.
Tilt. Pelvic.
The pelvis tilted. And glute max would be.
Buttock becomes
Max.
less firm.
Yeah. Can you just kind of hold the.
Take it up.
Whoa. Hold tight. Okay. One is just to visually look and see if you just see a difference. If one side, one glute looks more developed than the other, one looks flatter than the other. So that's a sign. If we have overuse of the hamstrings and the calves, what would you expect to see? Actually, visually bigger muscles on one side. So do you see that? Are they bigger on one side?
What is it?
Maybe a little on the right, but I don't know.
The hair is longer.
But you'll see that. You'll notice that sometimes the calf will be larger. You can see increase in size here. The hamstrings, you're going to see less. Hamstrings will tend to get bigger this way as opposed to that way on the calf. So the hamstrings is not so much a visual sign, it's a tactile sign. So rather than poking, use the backs of your fingers. So everyone come over here. And you just kind of feel the tone of the hamstrings. You can even sort of just grab and see if there's a difference. So feel the hamstrings and then grab the calves.
Not you.
Just grab the calves and see if they feel different or they feel bigger.
Just pull it.
Slightly.
Bigger.
Looks like a massage almost, isn't it? So predominantly visual inspection on the calves and tactile inspection on the And then on the glutes, pull the shorts tight again. Do you see a difference? Does one side look bigger than the other? Not really. Sometimes you actually really see it. The thing you do is tactile. So again, backs of the fingers. You let the patient know what you're doing. So I say, I'm going to check you out on your back right here. Be touching this part. Right there. Okay. On top of the short. Just kind of a little bounce like that. You just feel that there's a difference in tone. Remember, we're not looking for one that's overdeveloped because the muscle doesn't get overdeveloped. One is inhibited and it's going to be smaller, less tone.
Is it better to do it when the patient is standing or?
Yeah, stand. Okay, that's all you gotta do, just like that. So everybody, come on. Everybody. It's your lucky day. This is high school.
Are they feeling you up? Real good.
You have to redo it now.
Thanks. It's for Mabel. She's not here.
Yeah.
All right, so what's your assessment? Visually and with tactile sense, what do you see? Is there a difference in tone? Is there a difference in anything there? The right calf's a little bit bigger? Okay. A little bit, yeah, not huge. So we start to suspect there might be some kind of problem there. Because one of the things that I told you I've worked with brilliant people that taught me all this. Well, I developed one brilliant piece of this as well. One thing I've noticed is that if you don't have glute max and you're walking with all the other muscles, one thing you do when you do your toe off on your gait, you put a lot of pressure on your big toe. So I always look for callus on the big toe. If I see a callus on the big toe, I know the person's really pushing off. They're really having to propel themselves. They're not using their glute max to push themselves forward. They're using their big toe to push themselves forward and the calf. Okay, so let's look at your feet. If you lay down here, especially on the right side, maybe he's toeing off because he's got that hypertrophy right calf. Let's see. Is there callus there?
My patient. She's hot.
Not really, not really. So I mean, you'll just see this huge
Yeah.
callus right there. On
Is
somebody.
it a bunion?
Not a bunion. Well, in theory, my theory is that is what can relate to bunions as well because of that excessive toe off. But I don't really know if that's good. I think it's supported. Okay, so every visual sign's got confirmatory tests, right? So we have some visual and tactile signs. Let's do the confirmatory test, which is a hip extension test. So lay down on your stomach. And then you just lies down, and you tell the patient to lift their leg about 6 inches. I don't know how big that is in centimeters, but it's about that high, maybe 6, 8 inches. So what I'll do is I'll just say, you lift your leg about that high. Okay. And here's the important part. You gotta look for what happens here. Normally, when you extend your hip, what should happen is the brain should tell this part of the body to stabilize. The core should stabilize. Even when you're walking, the core should stabilize. And that muscle should engage as a primary mover. This muscle is going to participate a little bit, but not be the primary. And these muscles here should really not be involved that much. So as the core engages, you should see this kind of firming and tightening up. But we don't want to see any major deviation. We don't want to see this sort of thing happen in the low back. The other thing that would be a fail would be if right here that happens. So we want to see this stay in this position. We don't want to see any of that happening. That would indicate overactivity of that muscle. So I'm not telling him because I don't want him to be conscious of it and not do it. And I don't want him to try and activate his core while he does this either. Okay, so when I say go, you're going to lift this leg up and then take it down. All right, so go. Okay, so we didn't see any bending there and down. Check the other side, go. No, see the difference? So look right here.
When
This side again. See that real tilt and see that whole flattening there? And this side again. And that's more of a normal on that side. So what's happening here is that the core is not stabilizing, and he's using paraspinals and QL to assist in extending the hip, as opposed to using the core to stabilize here. So this is his left, which doesn't correspond to what we found there. So that was a minor finding. This is not super huge in terms of the fail. A lot of times you'll see a lot bigger deviation. So I would just chart what I found. I would just chart fail, I put like kind of small like down there, or small fail left hip extension test, pelvic torsion, whatever. If you had a significant complaint here, I might start to rehab it, I might do something about it. But he's not the best example for this. He's not a classic hip extension patient. You would really see big differences up and down. Let's look at what a hip extension, before hip extension gait looks like, and then we'll wrap it up. So we'll kind of put gait analysis in here too. Okay, coming up. And let's check out Sarah's gait. So demonstrating it? Okay. Well, think it through. If somebody has inhibited glute max, bilateral, lateral, what are they going to not? What are they going to do? What's going to be lacking?
Extension.
Hip extension. We'll still walk, right? So we're still extending our hip. Think of normal gait versus a gait that lacks proper hip extension. How would it differ?
walking.
Yeah. Well, first of all, normal gait is what's called a scissor walk. These are my legs. You should see this when I walk. You should see triangle, right? This is like scissors. Scissors, right? Scissor gait. This is a normal gait. My back foot stays planted. I have triangle here. That's a normal gait. If I don't have good hip extension, if I'm not pushing off with my hip, what's it going to look like? Just the picture. Yeah. People don't extend. They don't extend. It's pretty simple. You don't extend your hip. So it's walking without the ankle. It's walking without this. So all that happens, this leg goes forward. This leg never gets back in that position. So it's knee walking because you walk by bringing your knees up in front of you. So it's the way how people around school walk. They walk like this. So this leg never goes back. This leg stays pretty much in a neutral position. Small steps, everything is in front of me. My back foot never gets back there. Goes up front. Okay. So let's check out the gait of a few people here. Tio, stand over there. Have you there? All right. So Tio, start over there by the bars, and then walk down back. We'll take a look at you. Just your normal gait. So Tio, walk over here back. We're gonna watch you. Are you trying to take big steps?
Exactly.
Come on, your normal gait.
Come on, man. You don't walk like that.
Come on, run over.
Okay, not bad. All right.
Yeah.
Knee walker.
Knee walker. Uh-oh.
Welcome back. 2 steps. Okay. There, look at that walking. Wow, nice. So he's using his hip sensors. Okay. What do you think?
Oh, we're thinking already?
Yeah, it's
not so serious.
okay. Okay. So we had a good example of me walking here. So the retraining of this is going to be a couple things. It's going to be the gait, and here's how you retrain the gait. You tell the person to keep their back heel planted down longer. Let's take a little longer step. So it's going to feel really unnatural. So we work with the person, you say, don't lift your heel, don't lift your heel. Now you lift. Okay. Keep the heel down, keep the heel down, keep the heel down. Okay, lift. Keep your heel down, keep your heel down, keep your heel down, keep your heel down. Now lift. Because they're just lifting their feet up like that. They're just going in front of themselves. So, you tell the person to keep their heel down, take a little longer step. And that is as simple as it gets under retraining on the gait. It's going to feel really, really unnatural for people. It's going to feel...
It's more like bigger step.
It's not just a bigger step, but it's a bigger step with keeping the back heel down. Because you could knee walk with bigger steps. You can sort of go.
So it's like
Start jumping like this.
So, it's a bigger step with keeping the back heel down.
is it like mini lunges?
Without doing the lunge. Yeah. So that is your one part of it. The other part is you have to reactivate the glute max. And for people that that aren't very fit or well trained, there's one exercise that's shown to activate the glute max more than anything else, because you've got to deactivate the hamstrings, right? Because those two are working in tandem. The problem is that these two, the person's hamstring dominant. Using hamstrings to the glute max. So what you do is, well, you could have them just stand on the ground, which you don't want to tilt the pelvis too much. You externally rotate the foot. And the tough part here is that it's only hip extension. It's just hip extension. It's not this. It's just hip extension. There's no movement in the pelvis, no movement. It's just hip extension. Okay? Got it? Just hip extension. That's it. Just you do. Okay. No movement in the back at all. Shooting for the back. That isolates glute max and turns off and inhibits the hamstrings. All right, that's your first step. That's for somebody that is not well conditioned, really has trouble doing any sort of exercise. Next step, I'd get the person like in bridges. You guys know what a bridge is from yoga? Show us. Yeah, lay on your back.
Oh, good bridge.
Hold it. Yeah.
Go, Money. Break those old bones.
Okay. So, all right, now obviously something that's really out of shape, not the best exercise. Okay, so lift your hips. All right, what the goal of this is to turn the hamstrings off, because right now he could be using his hamstrings. If he cannot do this and deactivate the hamstrings, he's not working his glute max. So if he can't make that connection, this exercise is too advanced for him. You get him on the one, with the standing hip extension. Okay, feel his hamstrings. Okay, soft, turn off. That's enough. All right, so he's able to do this. Now, how can you make that more challenging? How can you make that more advanced? Yeah, so up again. Okay, lift this leg. Okay.
Oh,
Straight,
damn.
right? So now he's using his left one. Okay?
Yeah.
To make it even more advanced, he can start moving up, alphabets, whatever, different things like that. Okay? So that's your more advanced exercise. All right. That's all for today. We'll do hip adduction next. That's almost over.
Thank you.
All right, so start looking for this on your patients, especially, the glute max is a primary stabilizer of the SI joint. People with chronic SI problems, any SI problem, non-traumatic. Like in my mind, why does one SI joint hurt? Why does somebody hurt on one side of the body that day? Why? We walk with legs. I mean, I always look for explanations. If something's one-sided, it makes no sense to me.
So it's usually both sides.
No. Oh, the glute max? No, it's usually one side down.
But let's say the patient is bilateral SI joint.
Then that's something to do. So I look for the people that've got chronic SI problems. They've been a chiropractor before. They've done physiotherapy. They exercise, but their SI joint's always out. It's always achy here. So I always look, I'll say like, okay, so you sprained your ankle about 2 years ago, and they go. And then look at the toe, it's got a callus on it, calf is bigger. So you start to see these patterns. So, re-energizing, fixing it with max will help stabilize that SI joint. Graceful exit, okay. All right. That's it. See you Friday.
So why?
What?
Why does only why usually people have only one side pain?
Oh, well, because I have an explanation. It's because they sprained their ankle 2 years ago. They inhibited their glute max. The glute max is a big, strong muscle that supports the inside joint. And since it's inhibited, the inside joint is unstable. So it's chronically self-extending. Because if you can't tell me why, in a non-traumatic situation, the one SI is painful, it's like,